Okay, well, let's go ahead and begin. This is the August 25th, 2021 El Paso County Board of Health meeting. And welcome everyone, and welcome those few of you who are on Teams as well. So we like to start with a board member roll call. So Commissioner Tammy Bremer.
Present. Commissioner
Longinos Gonzalez.
Here.
Councilmember Sam Geek.
Here.
Councilmember Dave Donaldson.
Here.
Doris Ralston.
Here.
Dr. Richard Vu.
Here.
Ted Colas, fire chief. Okay, I'm here. And Kari, can you hear us out there on Teams?
I can. I apologize.
Looking for a KK on the screen.
Can you hear me?
I do,
Okay.
yes.
My apologies for not being there in person. I have a broken foot, and so I am not very mobile.
Well, I'm sorry. We'll take you any way we can get you. And please feel free to jump right in. Raise your hand. Vicky's really good at recognizing that, and we'll stop and hear what you have to say. Okay?
Okay. Thank you.
Thanks, Kari. Okay, you have in front of you the agenda, and I would entertain a motion to approve in a second.
So moved.
Make a motion to approve.
Okay, second? Second. I think we've got enough. Okay, all in favor?
Aye.
Okay, here we go. Board of Health comments. I have a comment. I'll hold on to that because I'd like to introduce City Council Member Dave Donaldson as our new board member. And where are you, Dave? There you are. Welcome. And maybe you could, I know you've had a long military career and other interests as well, health related, but could you give us maybe a brief bio about yourself?
Sure. And there's folks listening over that way too, right?
There are people all over the place listening. Yeah.
So my wife and I came here 30 years ago. This was my first assignment in the Army. And we had a little tiny 2-week-old daughter with us. We kind of fell in love with Colorado Springs and could tell we wanted to stay here, so we started planning ahead. Our kids grew up here. They graduated from local schools, our son and our daughter. I spent 21 years in the Army. You could kind of say that I didn't choose medicine, medicine chose me. Because when I went through Special Forces or the Green Berets selection, they then select a job for you. And the job they selected for me, there's 4 enlisted MOSs at that time, was 18 Delta or Special Forces medic. So that was the start. And that's a pretty intense introduction to medicine, really good trauma training. And we're introduced to all kind of tropical disease and things like that. Preventive medicine's a big part of that too. And then I spent several years, 4 or 5 years out at Fort Carson in 10th Group, but then went to PA school in the Army, or the Inter-Service PA program. Became a physician assistant in the Army and did that for 10 years. Kind of specialized in flight medicine at the end of that. Went to Iraq for 3 full years as a physician assistant and treated the locals in Iraq, their police force, but also lots of Americans for disease, leishmaniasis, and interesting things like that, oddball diseases, and all the normal stuff. After the Army, worked as a PA, several different places, one of which was out at Peterson in flight medicine, and then also ran a men's health clinic here in town. That kind of gave me some insight into the private sector medicine, trying to treat patients, and also the business side of it, you know, customers and trying to serve them. What else is good about me? So recently, I was elected, but I'm the representative from District 1. Hopefully I'll bring some of the kind of a unique perspective to the board, that background. And as a PA, I was also a paramedic through the 18 Delta stuff. So I've ridden with fire departments down in San Antonio. They tend to have lots of shootings in San Antonio, so it's a good place to go for that kind of experience. And up in Denver. Look forward to working on the board here and helping out with public health here in El Paso County.
Well, thank you. Thank you. Really appreciate your service. And your qualifications and look forward to getting to know you better, and I'm sure the other board members do as well. So thanks, Dave.
Thank you.
Good. Other Board of Health member comments as we get started? Please, anybody? Kari, you're good? Okay. All righty. I'm going to read a very brief statement from our El Paso County attorney, and I'll have some of my own comments later on in the meeting before a public comment section. So we understand that this community and some members of the public are very passionate in their beliefs about the risks of COVID, masks, and vaccinations. While the El Paso County Board of Health appreciates and respects your opinions, we expect members of the public to be respectful in discussing their beliefs, respectful to each other, El Paso County Public Health staff, and this board. And we will not tolerate threatening or harassing behavior. And just to kind of tee this up, that each speaker who chooses to speak during the public comment section will be limited to 2 minutes. They'll need to identify themselves, who they are with, if they're with an organization, and if they're, and I'd particularly ask if you're not from El Paso County and you wish to speak at our meeting to let us know that as well, where your home county is. Okay. We need to approve the minutes, and the last time we got together was June 23rd of 2021. So you have those in front of you. Any corrections, additions, deletions, comments? Otherwise, I'll entertain a motion to approve.
I move to approve.
Second.
All in favor?
Aye.
Finance and budget. We have today Lori and Samantha. So who's going to be first?
Good morning, board members. This is Lori Clayton with
Hey,
Financial
Lori.
Services. How are you today?
Yeah, go ahead.
So, let's see, do we have the July manager? There we go. Thank you. I'm going to present July financials as they are today. Typically, the revenue, as we've been seeing, it's trending as we've been seeing the past few months. It's coming in a little bit lower due to, again, resources focusing on the COVID response, but it is starting to catch up some, and it has improved slightly since the last time we met. We have no concerns really with the revenue coming in, and all the funding that we've been receiving is covering the necessary response to COVID, as well as our overall needs. On the expenditure side, we're showing still some significant underspending in both personnel and operating, and no real concerns there. And in addition, our net impact, so this would be the bottom number, the negative 167,108. This is revenues over expenditures, and that has come down a little bit since the last report, and primarily that is due to some of the timing in receiving the revenues, but we do anticipate that catching up and being in a more positive stance at the next time we meet, so in the August reports. So we have no real concerns there. Overall, everything is looking as we've been expecting, and there are no concerns.
Okay. Any questions from Board of Health members for Lori? Okay, Lori, let's go to the resolution to recognize revenue and appropriate expenditures for contract funding, and that's in the meeting packet. Page 14.
So what we have here is we're bringing forward a resolution to recognize revenue in the amount of $2.5 million and appropriate expenditures in the amount of $3.4 million. This is for the epidemiology and laboratory capacity, or ELC grants. This is to recognize the remaining of the round one that we received earlier in the year, as well as a portion of the $12 million that we received for round two that we anticipate spending in 2021. The remainder of that grant will extend, and we'll see it in the next budget that we come forward with at the end of the year for 2022. We'll see a lot more of that in that budget to support 2022.
Okay, Lori, thank you. So there's a lot of numbers here, but by protocol, what we do is we read the resolutions into the record and then provide an opportunity to discuss, and then we take a vote. So I'm going to go ahead and read, please bear with me. This is a resolution to recognize revenue in the amount of $2,567,956 and appropriate expenditures in the amount of $3,418,398 as contracted with the Colorado Department of Public Health and Environment, referred to here as CDPHE. Whereas CDPHE will provide El Paso County Public Health with total funding in the amount of $5,167,385, of which the remaining revenue of $2,066,956 will be recognized, and the remaining expenditures of $2,917,398 will be appropriated to the 2021 budget for the epidemiology and laboratory capacity for infectious disease enhancing detection COVID-19 grant, and we'll refer to that as ELC. Whereas CDPHE will provide El Paso County Public Health with funding in the amount of $357,633, of which $501,000 will be recognized and appropriated to the 2021 budget, and the remainder to the 2022 and 2023 budgets for the ELC Enhancing Detection COVID-19 Supplemental Funds, Round 2. Grant for this contract effective January 14th, 2021 and July 31st, 2023. And whereas this funding will assist to control the spread of COVID-19 in Colorado and the COVID-19 pandemic that has resulted in an unprecedented public health response worldwide. The project will strengthen and support local public health agencies responding to COVID-19 by funding personnel to perform critical containment activities such as disease surveillance, case investigation, contact tracing, and testing based on jurisdictional needs. The project also supports local responses to COVID-19 outbreaks, infection prevention efforts at healthcare and other settings, and promotes health equity aspects of the response. And whereas the goal of this funding is to support the project to control the spread of COVID-19 in the state of Colorado, and whereas the objectives of this project are to support public health personnel conducting epidemiological response activities for COVID-19, to increase knowledge of infection within the jurisdiction, and to incorporate health equity principles into COVID-19 epidemiological testing and vaccination response activities. And whereas expected results of all activities will contribute to the containment of COVID-19 and to provide high quality public health surveillance and epidemiological investigation of COVID-19 cases, contacts, and outbreaks in line with state and federal requirements and best practices. Now, therefore, be it resolved that the El Paso County Board of Health does hereby recognize revenue in the amount of $2,567,000, $267,956, and appropriate expenditures in the amount of $3,418,398 to the El Paso County Department of Public Health 2021 budget in the following manner. And then on the record, there's a tally of various amounts. So since you have this in front of you, board members, any discussion, questions? Lori's here on the line. Any comments, Susan, about this? This is great news. I mean, this is wonderful. This provides the oomph to do the things that we want to do to help prevent and control COVID in our county.
Well, and I'll just say, and I'll touch base about this a little bit later in my director's report, but March of 2020 is where things really took off for El Paso County with our first case, and then we had the first death. And at that time, we had less than a handful of communicable disease staff. And this grant has helped us ramp up to maintain and to levels that we need. And what I appreciate about this funding also is that it's not, ending by this year, because we know that this is going to be a long-term type of response that we need to maintain our team members. And this allows us to have additional resources to make sure that we're taking care of now the biggest, most populous county, as the census has determined in the state of Colorado. And so these funds are being put to good use with infectious disease control and prevention.
Excellent. Good news indeed. Any other board member comments about this resolution? If not, I'd entertain a motion. Oh, yes, Dave.
Yeah, Dr.
Please.
Kurish, just because this is the first time I've seen this, when I read it last night, I was just trying to get the numbers to add up. Even at the very end, be it resolved that the El Paso County Board of Health does hereby recognize revenue 2.5 million, 2.6 million, and expenditures 3.4 million. We're not trying to have this balance where, because it's over a long period of time, this is just covering a portion, or can you help me with that?
Lori?
Sure, I can explain that. Round two, we received $5.1 million of ELC funding. A portion of that was put in the 2020 budget and then moved over to 2021. So the majority of this funding is recognizing and appropriating the remaining of that $5.1 million. In addition, we've received the $12 million of the second round of ELC funding, of which we only anticipate spending about $500,000 in 2021, with the remainder of that going into 2022 and 2023.
Okay, then, so bottom line, we're spending much less than we have received.
At this point, yes, because it is a grant that goes through 2023, so we don't anticipate fully expending that round two amount all in 2021. So that will be carrying over to 2022 and 2023.
Okay, thank you for answering my question.
You're welcome.
Yeah, just a quick comment. The part of this that is particularly appealing to me is that because it's over a number of years, it allows us to hire staff, which with a lot of these short fuse grants does not. So this will really provide the oomph that we need to continue to pursue these programs that are helping us with COVID in our county. Yes, Susan?
And I would just add that, I'm very thankful for the expertise of our budget and finance office, because the majority of our funding, 70% and over, comes from grant funds, and they all have different timelines in the state health department and the governor's office. When this funding comes out, it's even could be a shortened timeline for some of the funding that we're able to use for the response. And as we know that it's challenging to hire staff quickly, and not only the healthcare but public health, and it takes time to hire and train and stuff. So with some of the delay, it's not as quick as we would like it to be. But again, what I'm very thankful for is that it doesn't cut off, say by the end of this year, and it extends, because I think that's critical to the health protection of our community, that we have those resources that are maintained and not cut off as we're navigating our way through this pandemic.
Great. Good news. Any other Board of Health member comments or questions? Anybody? All right. I'd entertain a motion in a second.
Move to approve?
Second.
All in favor?
Aye.
Thank you very much.
Thank you. And if I could just take one brief moment, I would like to welcome Samantha. I would like to welcome Samantha Montmanet, who is joining our team as part of her role is to support public health. Her new role is Health and Human Services Supervisor. So you will be seeing more of her in following meetings and in the future. So I just would like to welcome Samantha. Thank you.
Welcome, Samantha. Welcome to the team.
Thank you.
We look forward to hearing from you in the future. Okay, new business. And this is a really important one. Board members, you've had a chance to see this, but September is National Suicide Prevention Awareness Month. And there's a proclamation recognizing that also should be read into the record. So do you have that in front of you? Susan, do you want to read this into the record? Or do you want me to?
I'll let you.
Okay.
Thank you.
See if I'm equally dyslexic on this one.
You're doing
Okay.
well.
This is a proclamation of, this one's easier. Proclamation of the El Paso County Board of Health recognizing National Suicide Prevention Awareness Month 2021. Whereas there were 1,294 deaths by suicide in Colorado during 2020, and whereas 183 El Paso County residents died by suicide, and thousands of their friends and family were forever changed by these losses last year. And whereas in El Paso County in 2020, suicide was the 9th leading cause of death for people of all ages, and men accounted for a disproportionate 79% of those deaths. And whereas suicide is the leading cause of death among Colorado youth ages 10 to 17, and whereas El Paso County Public Health convenes the Youth Suicide Prevention Work Group, a collaborative of community partners taking collective action in support of youth mental health and suicide prevention. And whereas the local community and the Youth Suicide Prevention Work Group are also deeply invested in comprehensive suicide prevention efforts, including the Suicide Prevention Collaborative of El Paso County, an alliance of organizations and community leaders with a collective goal to reduce suicide deaths in El Paso County by 20% by the year 2024 among all age groups. And whereas September is National Suicide Prevention Awareness Month, and suicide prevention is everyone's business. And whereas El Paso County Public Health urges all El Paso County residents to be the one to take action and prevent suicide in our communities by asking about suicide directly and being there for those who are suffering and keeping them safe and helping them to connect to resources and following up after a crisis. Now, therefore, be it resolved by the El Paso County Board of Health, the month of September 2021 is proclaimed El Paso County Suicide Prevention Awareness Month in El Paso County, Colorado. And the El Paso County Board of Health recognizes that no single suicide prevention effort will be sufficient. Through the combined action of El Paso County residents and community suicide prevention initiatives, we can all work together to increase awareness, take action, and prevent suicide. And let me just make a quick comment. It wasn't too long ago, too many years ago, and Susan, you can back me up on this, that we, El Paso County, were somewhat notable for having a really high youth suicide rate. And that was so impactful that I remember seeing the change in not only attitude, but in action. And I think this is really an example where public health and community efforts together have been able to move the needle on this most important topic. So I really support this resolution, and I'm glad that we get to make this proclamation today. Any Board of Health member comments or Susan? Yes, please.
I wanted to acknowledge that the county commissioners provided additional funding through their critical needs to support our youth suicide prevention planner as well as our youth health and development planner. And through that effort, they're in coordination with the Child Fatality Review Team, which reviews cases, preventable deaths of 17 years of age and younger, going for some grant funding and then some critical needs funding, have been able to develop and maintain and really keep up the momentum of the youth suicide prevention group, which involves all of the different school districts, numerous different partners, parents, mental health providers, law enforcement, everyone that has a vested interest in the health and safety of kids and working together on prevention measures. And so I wanted to acknowledge the county commissioners and also the Board of Health, because our role is you know, we have to have staff and staff that is knowledgeable about prevention efforts and strategies that will benefit and working collaboratively with our community. So that is something that has been near and dear, not only to my heart, and I was involved in starting that up when I was deputy director for this agency. I worked very closely with our county coroner, Leon Kelly, as well as some other leaders in this community. So this is something that we need to not let up on. And that we need to continue to focus on. And I did want to invite all board members, as well as our team at Public Health, to participate in a NAMI walk, which is going to happen on October 9th, where we collaborate with them routinely, but they're going to have an awareness walk, and there's a fundraiser as well. But I'll send more details out about that, but that is something that we work closely with NAMI, and then Dr. Kelly, also our coroner, is the president of that board. I used to participate with COVID. I've stepped off, and I definitely would love to see you all join me on October 9th for that walk and have a public health presence to support our organization, NAMI, and they're a great resource, not only for kids, but for the entire community and mental health and well-being.
Well, thank you. That's good news. Is Dr. Kelly going to be there?
I believe so.
Well,
I haven't exactly asked him, but I'm sure that he is.
That would be great to attend that. Any other comments or questions about this proclamation? Yes, Kim.
Sorry, Commissioner Gonzalez. I am happy to see a very specific and quantified goal in one of these whereas statements. Whereas the goal is to reduce suicide deaths in El Paso County by 20% by the year 2024. And I'm not going to put you on the spot with those numbers now, but I would love kind of incremental updates as we approach the next 3 years on how we're doing on that. But I think this is wonderful, and I think Commissioner Gonzalez and I are honored to be sponsoring it for the Board of County Commissioners later this month as well.
Well, I think we'll be able to do that, because isn't that part of the annual coroner's report that's presented to the county commissioners?
Yeah, and we really appreciate the opportunity to get out in front of Board of County Commissioners, and also we recently were at the City of Colorado Springs doing a presentation with some of our partners, and you know, we have made progress. In 2014, Colorado Springs was put on the map with Palo Alto, California, and Fairfax, Virginia, which are the high spots for teen suicide, and that's not a designation that we want. So there's a lot of individuals and organizations that are working with us on prevention efforts, but we certainly will be able to track that, and we have that information readily available.
Good. Commissioner Gonzalez, yes.
Thank you. Yeah, I wanted to highlight, because my first year in office and on this board is when we were addressing that high level of suicide youth rates in El Paso County, across, in the country, and the great work that was done for the efforts to mitigate that. We saw several years, I think 3 years, and then what we saw last year with a little bit of a rebound, and so a rededication to this. But I also want to highlight, how can we call any information out that might be related to situations related to COVID, shutdowns. I know, I was very concerned. I think we had 1 or 2 suicides at the Air Force Academy, and they had been essentially isolated, 1 person per room with no interactions. Is there something that shows whether there was just a general trend, a rebound, or was it COVID related, so we have a better indication of why there was the slight increase last year? So make, I think, a little easier to address this situation if we can separate things that were maybe related to COVID situation and general suicide tendencies that we'd seen in several previous years.
And as you know, I mean, it's very complex, but when we go to your meeting, we'll have a more in-depth presentation and we can get into some of those aspects.
Good. Any other comments or questions? Okay. I think we need to vote on this. Entertain a motion and a second.
So moved. Second.
Okay, all in favor of this proclamation?
Aye.
Aye.
The next item of new business is something that we discussed in detail in our June meeting, and that is a pay raise and employment agreement for our public health director. And if you'll remember, we passed a resolution which really has the meat, if you will, of the what our intent was as the board and the basis for the employment agreement. Now, you have the employment agreement in your packet, and we're not going to read that all in the record today. But I think one of our El Paso County attorneys, Mary Ritchie, is here, who could maybe tee it up for us.
Sure,
Please.
thank you, Mr. Gerbis. My name is Mary Rich. I'm Assistant County Attorney. I just wanted to confirm that per CRS 25-1-508, the Board of Health does have the power to contract with a person qualified to be a public health director. And as you mentioned, per the recent resolution 2021-06, which was approved by this board on June 23rd, 2021, Ms. Whelan meets and actually exceeds these requirements, as the Board of Health found her leadership to be exceptional, and had established a pay raise for her, which is consistent with the pay rate that is in the contract. I would also note that our office did prepare this draft. It's consistent with other contracts, other employment contracts in the county. And I would note that there is some blanks on, it's at page 20 of your packet, page 3 of the contract, with regard to accrued sick leave and vacation and personal time. And I would just note on page 20 of the packet at footnote 1, Ms. Whelan has accrued 1,440 hours of sick leave, so that's what we will put in that space. And in the second footnote, the blank space will be filled with 286.93 hours of vacation plus 8 hours of personal time. Other than that, that is, there would be no other changes to the agreement.
Okay, thank you very much. Board members, you have the employment agreement. It's based on the resolution that we passed in June. And so I'd entertain we need to vote on this one. I'd entertain a motion in a second.
So moved.
Second.
All in favor?
Aye.
Okay. All right, thank you. My favorite part of the meeting, director's report. Susan, please enlighten us.
All right, so the main portion of my director's report will be on the topic of COVID-19. We did not have a meeting in July, and that's very standard related to the holiday and people taking vacation during the month of July. So we're resuming, and as previous board meetings, we have provided updates on our COVID response activities and where we are with as a county. And we will be providing some hyper local data to provide some insight on where we are with COVID in our county, as well as some historical information and where we are here presently, and then also some prevention actions that we are routinely making a call to action for the public and those to practice prevention for COVID. So with that, we're going to start out with Stephen Goodwin, who is our Chief Scientific Data Strategist and then our medical director, Dr. Johnson. We can take board member questions as part of the presentation, and then I will ask Deanne to provide some information specific to some of our updates on our partnerships in the community and how we're working together. And then I will provide a summary and a little bit of information around workload on our communicable disease staff and how we're doing there. So with that, Stephen, I believe that you're online.
I am. If we could go ahead and move on with the update, that would be great. Thanks for having me this morning. Next slide, please. So first slide here, just overall status check about where we are with COVID-19 in El Paso County. And that is, where we are is that after a period of decline that went into early July, the volume of cases has increased. Particularly in El Paso County, we went from 723, we had a 7-day average of 96 cases, to 823, a 7-day average of 193 cases, which is just about a 200% increase. Now, it's important to remember that this is consistent with the other counties in the state of Colorado. We're seeing a rise throughout the state of Colorado. And just to give you a sense, and I'll show you some pictures on the next slides, but the summer of 2020, we peaked at 87 cases a day. So that sort of shows you where we are now. In other words, we began at a higher level than we were in the summer of 2020. Now, interestingly, as I mentioned, the rest of Colorado, if we look at the larger counties in Colorado, the 10 largest counties we typically compare ourselves to by population, we had been leading the incidence forward during this period of time, but our rate of increase has slowed a little bit, and the other counties have caught up with us. And so now we're actually fifth, and again, I'll show you a picture where we can see this in the state of Colorado among the 10 largest counties by population. Also important and very important is that this year, and again, the single biggest good news is that we have vaccines and vaccinations, and that if we look at the hospitalizations, we see that most hospitalizations appear to be preventable with vaccination. So if we look since 6/1/2021, we see that more than 9 out of 10, just right about 9 out of 10 case hospitalizations are among the unvaccinated. And when I say unvaccinated, I mean not fully vaccinated. Now, if we looked earlier, this number would be higher. If we look later in the presence of the Delta variant, it's likely to begin degrading. But the point being that the vast majority of hospitalizations are preventable with vaccination. And if we could, let's move to the next slide where we can just remind everybody about where we are. And I don't deign to name these surges, but what I'm showing you here is a picture in El Paso County of COVID-19 cases using 7-day incidence. And you can see from left to right, really what we've seen, and this is consistent pretty much nationwide, although the exact dates vary. But we've seen, I would call these surges or peaks. So initially we discovered the disease way back in the spring of 2020. We then had a summer surge. You can see we went down, we had actually a bifurcated, a little bit of a bifurcated curve there. And then we had a summer surge, that's number 2. Then of course the major surge was in the fall before the advent of vaccines. Vaccines came online in short supply, however, came online initially in December. And you can see then we fell down to a lower level, but interestingly, we never got to an incidence level that was lower than our previous peaks, with the exception, of course, of the fall peak. You can see the spring peak or spring surge after that, and then the decline that I was just talking about going into our present climb at this point in time. So that's a picture looking at cases about where we are. If we could move to the next slide, I'd like to show you also a picture using hospital admissions. So I'm displaying the same information. Hospital admissions tend to lag say by a week to 10 days, a little bit longer after cases. And again, in a way, it's our most accurate data point when we have people admitted for COVID. So we know that we're never fully detecting all the cases, but we are detecting the people who have serious illness. And once again, you can see the 5 peaks over time. Again, time shifted a little bit to the right. Now, hospital admissions, again, very accurate. However, in our data set, the data tends to be a little bit delayed when we get these things. If we could shift to the next slide, I'd like to talk a little bit about hospital census. So hospital census, this is through a partnership with our regional hospitals. We don't have the complete data set because we began the collaboration with data that commenced on 1 June of last year. And so I'm not able to show you that the initial infection peak, but you can see the other peaks here. Now, Hospital census is a little bit different animal. We do get this data effectively daily. You can see on the right-hand side of this graph, we stopped receiving, consistent with the state of Colorado reporting requirements, late in the month of July, we stopped receiving data for the weekends, but it really doesn't make a difference for our presentation here. But once again, you can see the curves. And remember that the census is a little bit different because it's not exactly measuring the same thing. What it's measuring is the population in our regional hospitals who are part of a larger hospital system, of course. So that means not only El Paso County cases, but cases from other counties and potentially even out of state. But once again, this is interesting because, again, it's nice data. It gives it to us quickly. And effectively, it's a combination of the length of stay and the number of daily admissions. So it behaves a little bit differently. It also lags in time after cases and sometimes takes a little bit longer to decay. The important thing to note here, though, is that even though the cases haven't quite reached that March peak, our hospitalization census, both our hospitalization admissions and the hospitalization census are approaching that peak. So this is sort of indicative that as a system, as a state, we're seeing consistent cases that are spawning hospitalizations and therefore inflating the census. So it's important to note that we are at that point in time. If we could move to the next slide, that would be great.
Yes, please. Commissioner Gonzalez. Steve, just a moment.
Sure.
So hospitalizations today, are they similar to the previous ones in terms of proportion of El Paso County residents, or is there an influx from you mentioned out of county and perhaps out of state, or are any of these showing increases from out of county, out of state to this new increase?
That's a great question, and I can't answer that. I'm not sure, Dr. Johnson, if you're online and you have a contact where you could give us a sense of that. I really can't speak to that, Commissioner. But again, just looking at the aggregate data set, what we see is that our admissions, even of El Paso County residents, can we go back to slide number 13 real quick? So you can see, even if you look at the admissions, the previous slide, if we look at the admissions, you can see that we are approaching, in terms of, it's a little noisy data, but we are approaching the same level admissions that we saw in that previous peak, in the spring peak. So we would expect that the census would behave similarly. Dr. Johnson, I don't know if you're online and you can answer about in county, out of state, within the hospital system.
Sure, I can give some preliminaries too, and I'm here. So,
okay.
So I'll just stand up here so we can do this together.
All right, great.
Yeah, so when we look at our hospital, they are truly a system. And so they have contracts with outside states for accepting for tertiary care. It is for scope of practice and also utilization of those types of services. So we may need a transplant service. It's not safe, effective, or good use of resources. Plus, we wouldn't have transplant surgeons for every tertiary hospital. So the transplant service within UC Health is located in Denver. So that's just a fairly simple example of how we utilize a system to make sure that we're being effective. In speaking with the hospitals and some of the pressures that are applied when we have a pandemic such as this, they take priority to maintain that system and the contracts that they have for the care of individuals, which does include El Paso County. But let's take UC Health, for example. They are a regional trauma center, which actually is a huge asset for us because time is tissue. We want people to arrive quickly. So we love having that trauma center here, as you gentlemen will know from your military days. But they also have a response to Southern Colorado. So if you were, say, in Trinidad and needed a major trauma surgeon, they would fly you into UC Health here in El Paso County. If there is pressure on their system, they actually are taking triage and they can bypass our hospital and send you up to Denver. And vice versa, they may need to go from Denver down here. When we have spoken with the hospitals, they are keeping those contracts with hospitals. So like Nebraska doesn't have ICU beds, or if they do, very limited for peds. And so they have contracts with Children's Hospital for that. And that is a priority. However, if they don't have a contract, let's say Texas, and I don't know all their contracts, this is not my bailiwick, that they would ask Texas to be utilizing their system and their other states that they have contracts with. Does that help to answer?
Well, I mean, you answered the dynamics, how they do it, and I have no problems with them, how they do it. It's awesome. It helped, like you said, time is of the essence. But my question was, do we know if there's a difference between the proportion of, when I see the incidence increasing, is this relatable from now and the previous peaks of El Paso County residents, or are some of this from outside? It's apples to apples, apples to oranges, if we don't know that. If the peak was before all El Paso County residents, and then this new rise is half El Paso County residents and half out of county, out of state, then it's not the same proportion of increase. So that's my question. If we can't answer it, that's fine, but that's my question.
Yeah, and I think it's more complex than, a simple 1-to-1 ratio, to your point, which is, I think, the point you're making. But what we're seeing is that as incident rises across all states, hospital census rises, and then those pressures, come back into play. And so we would anticipate, as our census is rising, that the pressure from El Paso County on our hospital systems is going to be local, not just from outside. Stephen, and maybe you can speak to, I don't believe that we get any kind of data on county of residence for these.
No, I mean, indications from me are that it's consistent, historically consistent.
Yeah.
So to answer the question, we don't have a breakdown.
That's fine.
Could I ask one question to kind of just thoughts? It's similar. Has the criteria changed at all from, say, back in May when we had the peak for admission to the hospital to who's being admitted now?
Not that I'm aware of.
And I would assume not, but do we know? No, it's they're being admitted basically on the same criteria, maybe Dr. Booth.
Even though I do not know, I would imagine that we have more outpatient therapeutics now than we previously had. Then my assumption would be that there might be patients who would have been admitted several months ago are now being treated as outpatients.
I know that was part of the push to really understand what could be handled as an outpatient, particularly if you look at the peak back October to January, when those pressures were really high, the setting up of outpatient services to try to minimize how many individuals needed to come in for that tertiary care. And to my understanding, that has not shifted at this point.
Yeah, that's exactly right. Those lessons learned have been incorporated since that time.
Oh, yeah, a quick question. How does this hospital census overlay with capacity? So ICU bed capacity.
It's always a really good question. So I know that the hospitals are like any other emergent service. They expand to meet the call upon them. So they, if you have a disaster where there's suddenly 50 people in your ER, we rise to that occasion and we move the gurneys in and readjust. So as far as census goes, I know that there is increasing pressures with numbers of beds that they have in units, and then expansion of those units to bring the right services. So it may not be a traditional ICU bed, but bringing those ICU services to the beds that are available. And then making sure that the staffing models are as appropriate as possible. And I think staffing is going to be one of our bigger challenges as we move forward. There is a shortage in our nursing and other providers at this point after the previous year.
Thank you. I wanted to add that, as a refresher, that, when we started out our response, Dr. Johnson has initiated and developed a clinical operations group which meets routinely, partnerships with our 3 hospitals, Children's Hospital, UC Health Hospital, Penrose St. Francis, Dr. Vu's operation, and many more, and keeps close ties also to the military. And so while we're providing and have been committed to providing transparent data with what we have, I think that the questions are always really good, but know that that Dr. Johnson is meeting routinely and keeping in close contact with our medical directors of our healthcare institutions, because there's more discussions and that need to be talked through as we are navigating through the pandemic. And not this board meeting, but at the next board meeting, we'll provide a presentation about, entering into respiratory season as it relates to RSV and influenza and how that's going to overlay with COVID. And so I want you all to know that we do have, through Dr. Johnson, very close ties, and also on our Vaccine Consortium participation, where we discuss policy and what dynamics are happening. But to Dr. Johnson's point too, is that staffing is kind of the critical point. And I know that folks are exhausted and caring, and that's a real tough job, because, and we'll get into this also, prevention and how we can ease that pressure through prevention measures and help our community out. But that's something that is always on my mind, because I know that my staff has been working tirelessly too on the front lines, and you don't always see them, but they're still extremely busy in the hospitals and also on our case investigations, and they're on the front lines. Whether that's been seeing that or not, or hearing from them, we're definitely cognizant of that as well.
I just want to pile on to that and say thank you, Dr. Johnson, because before you came on board as our medical director, we didn't have nearly the communication, the transparency, the relationship with our community hospitals that we do now. And I sure appreciate all of the efforts that, I think that's a game changer, and appreciate your great experience and prior relationship with the hospitals to be able to bring that along and help us in our fight against COVID. So thank you.
Thank you. Appreciate that. It's really a privilege to get to work from this perspective with them and to have that collaboration. So
Game changer. Board of Health, yes, Fire Chief.
One more question. This might be for Stephen, and I don't know, maybe you haven't gotten here yet, but I've heard anecdotally that the admissions to the hospitals are now younger than they were previously in our previous spikes. And are we tracking that?
We are, and we actually have a little bit of a slide to show the age demographics of our cases. But you're precisely correct. Since we began vaccinating our more vulnerable population, which fundamentally means older, they've been less represented within the hospitalization population by a dramatic amount. So the average ages of hospitalizations and those that do show up in the hospital are trending younger. It's still the case, of course, that some older people who've been vaccinated are showing up in the hospital, but more older people who haven't been vaccinated showing up hospitalized.
Stephen, why don't we resume, and then you can dig into that a little bit more, because the 10 to 29-year-old age groups, we will have.
Absolutely. Absolutely. And I would like to say one thing as we get ready to proceed here, and that is that this fifth wave is really due to the new virus that we're seeing, the new revision of the virus, of course, called the Delta virus. And it's pretty phenomenal when you think that it's multifactorial, right? So we have a lot of behaviors that have fallen away. So there's less social distancing, less masking, of course, which means more disease exposure. But the other thing we have is we've vaccinated a significant amount of our population. So we're seeing a new, more transmissible variant against vaccines and with additional behaviors in play. So all these things together, it shows you that we're still doing pretty well overall especially when you look around the United States, you look, for instance, at states like Florida, Louisiana, Texas, Mississippi, you see where they've really been hit very hard, challenging their medical care systems. Colorado, state of Colorado, El Paso County is not presently in that circumstance. So let's move to the next slide, if we could, slide 15, which is one of my favorite slides. And this slide is showing us, this again is the 10 largest counties in the state of Colorado. We've been tracking this data really since we've had it available. Several weeks ago, in fact, I believe since we've last met, we made a change. We don't track vaccination rates. We're now tracking full vaccination rates. And that's because we know that against the Delta variant, it's important that people complete their vaccination series. So the efficacy or efficiency of the vaccine with a full series is dramatically better than with a partial series. So we're now tracking left to right, we're tracking full vaccination rates. And from the bottom to the top, we're tracking 1 week incidence, which remains the state of Colorado's methodology for tracking disease rates. And you can see if we look from left to right, and this incorporates federal vaccination figures. Now CDPHE is delivering this data to us, including the federal figures. You can see we're still lagging behind as a county. So when you look at full vaccination rates, we're now at about 58.8. We're almost at about 59% presently. And that puts us third in this shot group. However, when you look from the bottom to the top, you can see we've now fallen into the pack. We're the fifth in the pack now. Previously, we were typically the leaders. So this speaks a little bit to our continual caseload early coming up from July, and the others have caught up with us, and many of them have surpassed us. So that's our present shot group. Again, left to right, percent of population fully vaccinated that are eligible, and bottom to top, we're looking at the vaccinations versus incidence. And this is behaving as we expect. That is, the more vaccinated you are, the lower your incidence generally is going to be, although it's, again, multifactorial. And now if we can move to the next slide, which really shows us, it's kind of a rich data slide. It's a little hard to look at.
Stephen?
Go ahead.
Hi, Stephen, this is Rick Vu, the previous slide.
Sure,
Would you have a comment regarding Pueblo?
Pueblo is an outlier, sir. We would love to understand what is going on with Pueblo. Yeah, they've been interesting throughout the pandemic, and you're right, they jump off the page as an outlier. So the short answer is I don't know.
Okay, thank you. One other question, you may or may not have the data. Full vaccination rates, so 2 doses of mRNA vaccines or 1 dose of Johnson & Johnson vaccine. Would you be able to separate out the data of mRNA vaccines, full vaccination rate versus 1 dose of Johnson & Johnson vaccine to see if there's any difference?
I currently don't. One of the challenges that we have with the the data that we get on the mRNA vaccines, particularly the Pfizer vaccine, came to us from other countries, and coming to us in time. But because of the relative low take-up rate of the J&J vaccine, we don't have as solid of data. But as soon as these studies come through, we'll be able to compare them. Again, going into it, we suspected that the mRNA vaccines had a slightly better efficacy against disease, but as we're gathering data in the presence of Delta, of course, those numbers are degrading. So, they may be converging. All the vaccines do protect against serious illness. And again, those numbers are still coming to us. It's harder to get the numbers for the J&J vaccine because of the relatively smaller number of people inoculated and only in the U.S.
Hey, Stephen, this is Councilman Donaldson. Could you maybe try to explain or give us some information on why you think El Paso County, with its fully vaccinated rate of 57% or 58, whatever this red dot reflects, then has a lower cumulative incidence rate than Douglas County at 70% and Larimer and Adams?
Yeah, these are fascinating questions, and I really honestly can't answer this. Remember, though, that population immunity is a product of all immunity. So whether it's immunity from a natural infection or whether it's vaccine-induced immunity. So when we take all these together, we're only measuring here the vaccine-induced immunity, or one aspect of it, right, the full vaccination. But when we look at all of the people who've been infected and their immunity, now remember, it's looking a lot like vaccine-induced immunity is a superior immunity in terms of both its efficiency, and how long lived it is, right? But we have to account also for those who've been naturally exposed. So there's that factor which we're not capturing, in this data set. So it's very possible that El Paso County, by virtue of the combination of those two immunities, belongs exactly where we are. But that's a fantastic question.
Let me just follow up on that.
Yeah.
And do you think there's also a possibility that the Delta variant breaks through the vaccine at a higher rate than previous?
Oh, it clearly does, sir. Clearly. So in fact,
So that can be reflected even if you have a higher vaccination rate in your county, your rates can still.
absolutely. So we do know, and we're beginning to get data. Again, the sad thing of it here is it's time. It's time for these data to be gathered. But we do know that the breakthrough rate, the Delta variant, is so fantastically transmissible that we are seeing the vaccinated that have breakthrough infections. Now they tend to be milder, and they are protected, amazingly protected against significant illness. But the one factor, not only can they become sick and carry the virus, but they also can carry it and be infectious. It's not clear exactly how many are that way, but they can be just as infectious as someone who's unvaccinated. So all of these factors are in play. So, that's why the Delta variant is very interesting. We have to layer protections. So it's not enough to vaccinate, even though it's our principal weapon against the virus. We also have to be wise about understanding exposures, getting tested if you feel sick, all the standard things we know how to do. It's not as simple as simply just getting vaccinated, right? So we got to layer our protections.
Dr. Johnson, you had a comment, please?
Yeah, I was going to, so Stephen just got to it.
Oh, okay.
Which is how important it is to remember this is a multifactorial proposition before us. And so the vaccine is our strongest tool, but particularly as we see Delta, and we'll get into the Delta variant even more detail, the continued layering of those public health preventive measures is going to be essential. And so, you have to, this is just looking at one factor, which is just the vaccination. If we talk about masking and social distancing and cohorting, so keeping our, intimate groups small and consistent inside, outside, over, in, all of that.
And it's a great point. On this slide, we could add that dimension of recent infections within the population to try to measure sort of the natural immunity. And it may even show a more clear picture. Here, we're missing that dimension entirely.
Commissioner Berman.
So breakthrough cases were mentioned. Are we beginning to track that?
That's a great question. And as you know, early on, the CDC made a decision not to track breakthrough cases except for hospitalizations and deaths. Since that time, CDPHE is trying to get better at tracking breakthroughs. So we're beginning to see some better data in that space. And again, we expect that we're going to see, in the presence of the Delta variant, more breakthrough cases than we'd seen earlier. But we didn't have good data on that. So that's a really great observation.
I was just going to say, with the Department of Defense requiring the military to get
Yes.
vaccinated, maybe that will help our community.
Absolutely. And remember, just earlier this week, we've had the first COVID vaccine approved fully by the FDA, which is the Pfizer-BioNTech vaccine for 16 and above. So that's extremely exciting. That means a lot of organizations now will feel more comfortable mandating vaccines. And as much as you don't like to see mandates in the freedom sense, in the public health sense, we like to see people vaccinated. So we're very excited about that. And the DOD in our area is very influential. Even just uniformed will make a palpable difference. But if it expands to contractor and civilian workforces, it will make even a more difference. And it would push us in the fully vaccinated phase to the right on this chart pretty significantly. And again, that would be all good for us.
Here. Other Board of Health member questions before we continue with this briefing? No? Okay. Stephen, what else have you got?
Let's move to the demographic slide. So again, this is a data-rich slide, and I'll let it just sit on the screen. And Dr. Johnson, if you're up, you're also can talk to this as well. So what we're showing, first of all, let's look at the little shot groups. So what we're doing here is we have columns by age decade, starting on the left with 0 to 9, 10 to 19, 20 to 29, and so on. And the four colored are showing you the actual number of cases identified. Now, remember, we always only identify a subset of cases, right? In fact, one of the challenges with being vaccinated and having a breakthrough case is you don't tend to think of the fact that you might have COVID. So you don't turn yourself in to get tests. So we underreport most likely breakthrough cases. But if you look at this May, June, July, August, and you can see in May, it's quite surprising. May, we were still in a large bump, right? That was a surge. And you can clearly see that the blue columns are painted across the chart. And you can see there were a lot of cases in May. And then June and July, you can see we had fewer cases, but stepping upward. And then August, I have to say, it's not marked on the chart. It's bad data presentation, but August is a partial month. So we're only seeing 3/4 of that month. And yet you can see that the August is surging, right? So in August, we're seeing a surge of cases, not matching May, but well on its way up. So that's the first thing to look at. Now, the second thing to look at is that dotted green line shows you the relative percentage of those age groups in our population. And so we would expect that basically the 20 to 29s would be the most people in our population. And again, you know, how are they represented within cases? Now, the blue line shows you who's been vaccinated. So that's the vaccination rate for the population. So the vaccines actually are behaving beautifully. It's a little hard to interpret off of this graph, but the more vaccinated populations are underrepresented within identified cases. Again, that's legitimately because of the effect of the vaccines, but it's also, there's some reporting phenomena that we talked about. And where the break point actually occurs, it turns out the younger people remain underrepresented all the way really up to 10 to 19. And that is just dynamics of disease. But then the 20 to 29, 30 to 39, and 40 to 49 are overrepresented. And again, it's a little hard to see it on this graph, but that's what we're showing here. So the age groups that are really getting to us in terms of going out there and acquiring the disease are from 20 to 49, basically. And this is, as more of them become vaccinated, this will become less of an effect. Again, these age groups, of course, tend to be the most socially active, and they're out there and engaged. So it's a multi-factor thing. But you can see this demographics, very interesting chart. Again, underrepresented with youth still, underrepresented over the age of 50, in that other group overrepresented. Questions or comment?
Stephen, I think that Ted had a question around demographics and hospitalizations.
Sure.
And that was, what are we seeing with hospitalizations and age demographics?
We're continuing to see a lowering of average age. So the age profile of hospitalizations continues to shift lower. Ever since basically the springtime when the first vaccines went in and full doses were available, we've begun to see that. Again, the most likely people to be hospitalized with this disease are the older, but as the older became vaccinated, their numbers became relatively lower. So that in fact, our age of hospitalization continues to go down.
Do we have a slide with demographics from the hospitalized, like
on
age?
this presentation? I do not, but we can certainly put one together for you. And we do, on our public website, we do show you the demographics of the hospitalized by age group. So you can select a date range and see the demographics.
And this are just maybe I think maybe you'll just know these off the top of your head. Comorbidities of people being admitted to the hospital, is it virtually everyone has a comorbidity, or they're above 80 years old, or 70% of admissions meet those two?
Dr. Johnson may be able to speak to this a little bit better, but the short answer is basically yes. Most of the admissions are related to older age or comorbidities. Not all, of course, but most.
Yeah.
No, and anecdotally, I think that we'll need to continue to track that kind of data. Anecdotally, when talking to colleagues, they're seeing, as we see more young people, it's not necessarily comorbidities, although obesity is still predominant. But there are other factors that come in. So you might consider like pregnancy at the point of delivery, because by definition, we're immunosuppressed to be able to keep that little parasite alive and grow it. And so at that time, those women are more at risk for some more serious illness with COVID. So for vaccinating, it is safe and effective in pregnancy, and we would really want to promote that that population again be protected. So there's a lot of information yet to come, but yeah, certainly those comorbidities make you higher risk.
And then just in relation to the census data we saw earlier, what's the average stay in the hospital? If you get admitted for COVID, are you in for, and I know if you're 80 years old, it's going to be different than if you're 25. We
Well,
certainly have a typical week,
Yeah.
2 weeks.
So that's a really hard, once you get, if you're just in the hospital, so let's say you're on the floor, it probably is like 10 days to 2 weeks. But once you enter the ICU, I think bets are off on that. And there are individuals that are there for potentially months.
Can I also add one of the stronger risk factors for being severely ill and being admitted to the hospital because of COVID-19 is being unvaccinated, as we all know.
Absolutely.
Well, let me add to that. I've heard this recently, and maybe we can, somebody here, Dr. Johnson, maybe you can back this up, but I heard that if you, in order, people who are vaccinated, people who are unvaccinated, excuse me, are 26 times more likely to be hospitalized. Is that in the ballpark or an exaggeration?
So I don't know about the, like if we were to transpose all the math, like to do that in my head, but I know that over 90% of those who are hospitalized are unvaccinated.
Okay, so
That's right. If we were to look at this slide, if I may, if we were to look at this slide, this exact same slide, you would see that the big thing is vaccinated versus unvaccinated in terms of hospitalization.
Okay.
During this time range, it would be 92% unvaccinated with this disease in the hospital. And to the length of stay, our length of stay drops dramatically after, say, 7 or 8 days. So it's sort of a curve that goes straight down. And then, as Dr. Johnson said, you could have somebody in there for 3 months.
Okay, so that's perhaps an oversimplification. What I said, but is generally true, is that if you're unvaccinated, you're many times more likely to be hospitalized.
Absolutely. In fact, you could just in this time range, it's again 90+% of those who are hospitalized for COVID are not vaccinated. So we can even construe those as unnecessary hospitalizations.
Okay, I don't mean to belabor that. Yes, Dr.
Stephen, when Dr. Johnson starts presenting on the Delta, could you do a quick look at our data dashboard so you can get back to us with more age demographics related to hospital admissions, so we can make sure that board members have that information before the presentation is over, please?
Absolutely. And let's go ahead to the, if we could, let's go proceed to the next slide. And Dr. Johnson, you can jump in here. So again, this surge is due to this variant, right? The Delta variant. I think of this as sort of the third revision of the virus, and viruses, as they move into a new host, that being humans, adapt very quickly to serve themselves. And serving themselves means right now multiplying effectively, spreading effectively. So the first variant that spread, it didn't even get a good name. It was just called D614G. But then very quickly, the next variant, the UK variant, sort of took over and moved on. And we call that Alpha. But the Delta variant is even much more transmissible than its predecessors. And that's the one that we're currently suffering from pretty much worldwide, almost universally within the state of Colorado and most of the United States. Now, it's important to note that how do we know it's Delta? Well, we know it's Delta because we sequence specimens. So when we get specimens, some specimens we're able to sequence. We just take a small subset, and this is done currently at the state level. But it's done consistently, so we're sampling consistently. But we don't know each person what variant they have. But we do have a sampling, and it's important to note that this sampling is sort of looking in the rearview mirror. So the results, just by virtue of the process, are delayed for typically at least a week, typically 2 weeks. So we're actually looking at data 2 weeks ago to say this. But within the state of Colorado, 99% of the cases are likely Delta. So that's how we know it's Delta. Now, Why is Delta a concern? Again, it's a concern fundamentally because it's radically more transmissible than its predecessors. And so it means everybody's at higher risk of exposure to the virus. So when I go to the grocery store, if I go out to eat in a restaurant, or anywhere where there's crowds inside poor ventilation, we know fundamentally we're moving it by sharing air. We're moving it by the classic respiratory, even aerosolization. So the unvaccinated are especially high risk of infection. And remember, even if somebody's been infected with a previous variant, that immunity wanes over time, just like even vaccine-induced immunity, and they're subject to reinfection or infection. Even the fully vaccinated, we've discussed this a little bit, are subject to breakthrough infections, which have been undermeasured, right? And we expect going into the future that we're going to see more of these, but they remain protected by virtue of their vaccination series, a very low risk of serious illness. The one new bit of information in the last several weeks is that they may also be infectious, which means, again, we want to layer those protections. We want everyone masked when they're moving into crowded, poorly ventilated circumstances. And Dr. Johnson, did you want to pile on here?
Sure, I think that the important piece here, like when we talk about it being more infectious, it is also because it has a higher viral load. So when we look at Delta and we're looking at the clinical case, you have higher numbers of the virus in your nose and in the droplets, which is why even if you're vaccinated, those numbers of virus that can be in those droplets multiply, so you have the potential to be able to pass it on. Where with a native or the UK variant, we didn't see that kind of viral load once you were vaccinated. So again, that is why we are adjusting our recommendations and ask people to put their mask back on anytime that, whether you're vaccinated or unvaccinated, when we enter into a situation where we're in an enclosed space, just so that we can respond to what the virus is telling us about itself. We need to pay attention to that data.
And Dr. Johnson, when you say more, it's order of magnitude 2 or 3, right? So it's 100 to 1,000 times more viral load. So it's a much more efficient virus at spreading itself.
Okay, so ready to move to the next slide?
We are, and this is for you.
Next slide. So that brings us to that community approach of, our community approach to layered prevention. And we've talked about this to the point that I'm sure people are tired of hearing me speak to it, but it is truly a cumulative impact that we have from our individual choices. And it is critical that we continue to be diligent in this approach. We know that the vaccination is our strongest tool that we have, but it is not our only tool. And we need to make use of all of the tools that come to bear when we talk about prevention and infectious disease. There are multiple tools that we might use. And in respiratory viruses, they are staying home when we're sick. It is covering our face with a mask or face covering, social distancing. Getting tested is going to be key. And even if we're vaccinated, to go ahead and step into that, we still have testing sites available. There is our free sites. And then our providers are still doing testing, and we are really grateful for their partnership in that. But also participating in our case investigation, contact tracing, quarantine, and isolation. This is still a mainstay of public health and public health prevention. And so we really are asking our public to join us and our case investigators who are still diligently really tracing this. We need to understand the virus. We want to stay ahead of it, understand where it is in our community, and to understand if we're seeing it begin to change again, because it is always working for that perfect niche in which it can multiply and continue to spread. The next. When we look at vaccination activity, I think that this is interesting and people are, wondering what's happening with vaccination. And we can trace it from when it first started in December of 2020. And you see these spikes and it's continually increasing. Remember, we had limited doses and we had expanding population. that was available to be vaccinated. So we started with those at most at risk, the elderly, and then our frontline workers, and expanded. And then you see in that March, April timeframe, it became generally available to our general population based on age. And then it began to drop off as those early adopters, those people who jump on board when you're offered something, began to be saturated. And so then we had to gather more information for people who were more hesitant about the safety and efficacy. And at this point, we know that millions of people around the world have been vaccinated. They've been vaccinated safely. We've talked about the efficacy of these vaccines. This week, we have the FDA approving fully the Pfizer vaccine, and it will be also called Comirnaty, I think. I'm not sure.
That's new.
Comirnaty, I think.
Comirnaty, is that correct, Stephen?
Comirnaty, I think, but I'll have to look up how to pronounce it. Who thinks of these things?
So we're looking, you know,
That's
I
new
think
news.
pharmaceuticals just think of like, let's see if we can create a whole new.
This is Pfizer's brand name.
Yes, so you will hear Pfizer vaccine, also known as Comirnaty, but it may have a different pronunciation. So they'll begin to be used
All right, Board of Health
interchangeably.
members, there you go.
Yeah. So I just want to make sure that we are beginning to use that terminology so you get used
It's the
to
approved vaccine.
the new and improved.
Okay.
Actually, what it's doing is it should really help us rest in the safety and the efficacy of this vaccine. The FDA has a rigorous process. It has been the gold standard for the world in how we look at vaccinations. And, you know, we look at some of we don't know anyone at this time who has polio here in America, and it's due to vaccination. And the same with, you know, measles, mumps, and rubella. We intermittently will get little pockets, but we certainly are not struggling with that. And the big win has been our vaccinations. So we are seeing that there still is some steady uptake. We want to see this rise as public health, and we want to encourage people to take advantage of this really powerful tool that we have to put this pandemic behind us. And next. So why vaccination? Well, we know it prevents the serious illness that results in hospitalization and fatalities. Our breakthrough cases, even if we do see them, are shorter and milder. We were just talking about this at the clinical ops group. It reduces the spread to others, which is, you know, we can all embrace our civic duty and embrace how we care for those that we love. It prevents opportunities for new variants to emerge. And I think this is one that we really have to get our minds around, particularly with the propensity of COVID to adjust to that new niche that gives it a hand up. It is safe and effective, as we just talked about, and then natural immunity is not as protective, and we've had some real questions about that. The data is finally really coming in to help us understand. It is just not as it's not as durable, and it is not as stable known dose. So we don't know that we're getting the immunity that we do with the standard vaccine. And CDC just released that unvaccinated who have natural immunity, who have had an infection, are 2.34 times more likely to be reinfected with COVID, to have a second infection with COVID than if you were vaccinated. So again, just really important data about why vaccine, even if you've had a natural infection, we are still advising that you go ahead and get vaccinated. Next. And everybody's hearing about the need for a booster. As we step into understanding the immune response and understanding this vaccine, we are seeing that there's some waning of immunity right around that 8-month period. And so currently a third dose is approved for those who are immunocompromised, and we anticipate end of month, early September, that the general population will be approved for a third dose 8 months out from their second dose. And there is ongoing conversation about if you got J&J being getting a booster with the J&J versus moving into a mRNA vaccine to cover that. This is not uncommon with vaccines. We see that we need a series in polio, right? We do it in our childhood vaccinations. We do it for the MMR, measles, mumps, rubella vaccine. I think it's a through dose, if I'm remembering back. It's been a while since I gave that particular one myself. Though we offer it here, and
Blue shots?
Flu shots are yearly because it tends to be more variable. So it is not of concern. It fits with the physiology and what we would expect with virology and how we impact and vaccinate against infectious disease. So actually another incredibly powerful, and I don't have the exact numbers, Stephen, but what was the actual impact of that third dose? It increases our immunity by multiple times.
Yeah, it was remarkable. It looks like in the first studies that were published, 3 to 4 or better in terms of measuring available antibodies. So it's a phenomenal boost. And that's, again, the same vaccine that you originally took.
Yeah.
Well, if you were kind of in a study when they started these,
Say again?
if you were in a study when they started these vaccines and you were called by like UC Health to come and get the shot, are they going to do that again, or are they going to expect you to go get the booster?
I mean, if you were in a research study?
Well, I don't know exactly how to put it.
Yeah.
I was called in December on a Saturday night. Do you want a vaccine? I said, sure. I went in the following day, got the vaccine. 6 weeks later, I got the second vaccine. So now I'm wondering, are they going to call again? Because at that point, I was told that it was some kind of a study group or a group.
Well, there's a process that those processes are being developed. And absolutely, I think that there will be probably a combination of providers being able to get those flagged in the EMR, electronic medical record. So there is an ability to ping someone, whether electronically or through a phone call. But I would ask our population too to, hopefully pull out your vaccine card.
I got my card.
We know that some people have already lost theirs, and we're working on making sure we have a process to get those back to people. But look at that, and at that 8-month mark, certainly pursue it. There's nothing to prevent you from calling and saying, is it time for my vaccine?
But it is a great point that, the way that these studies are typically done is you do extend a study to add these things because you already have antibody information and detailed information. It's also interesting to understand that it's getting more and more difficult now for ethical and logistical reasons to do vaccine studies against this disease, right? Because now we have approved vaccines in the field, and that always complicates things.
Do we know both the efficacy and impacts of crossing over the different manufacturers?
That's a great question. There are in other countries, UK in specific, they chose that as a strategy. In the United States, our strategy was to complete the doses on time and to stay with the same vaccine so far. But there are studies in play to understand if crossing vaccines gives you a superior response.
We have yet to see any data on that, though. It is being gathered. So.
But that's not an approved.
That's
schedule in the United States, is it?
Not in the United States at this point. And as we look at boosters, we will begin to have some more recommendations regarding that.
And J&J just published today, or they are publishing the results of their boost study. So that should be available shortly.
Yeah.
Kari has a question.
Yes.
Oh, Kari.
Thank you. To Councilman Donovan's question, it's a good question about UC Health reaching out. We have not made any of those plans yet, since right now the boosters are only approved for immunocompromised. But I will bring that up with leadership, and I can report back if there's going to be such a plan. It's a good question.
Thank you, Kari.
And Dr. Johnson, did you mention that we'll be working with the State Health Department to outreach to the nursing homes as a priority with the booster?
No, I hadn't mentioned that, but that's true. We will be. working and, you know, in conjunction with the state to address those who are in more vulnerable populations, to ensure that we get that vaccination out. Also addressing access to care. We had a Operation House Call, which the fire department has helped us with. And so we'll need to develop processes for revisiting that, as well as working with our partners. And we already have questions from some of the partners, Matthews View and Peak Vista, who really put together some of those mass vaccination sites and how we can help address that, because they're anticipating that there potentially would be those patients who came to them for their first vaccines who are going to want to come back to the same site, even if they haven't necessarily been enrolled. And so making sure that these lives are covered for access to that vaccine. And so more to come on that. And we anticipate, again, a lot of coordination. And anytime we do this, the first three principles are communication, 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 right? So that we make sure that we're dotting those I's and crossing those T's. And we're always happy to hear when people, you know, think of something else where we can step into that gap to make sure that we meet the need of our community. So that's our vaccine update. We are working with a consortium. It's more than 30 providers. Our major healthcare providers are in part of that, as well as the military. We have over 100 locations. We just sent off a letter asking all of our primary care to join us in this vaccine effort, and assuring, you know, that we have cold chain and the supplies that they need to be able to offer vaccines safely and effectively, and making sure that we expand that education and administration of vaccine. We are working with our schools. If there are any other agency, potential churches or other sites who would like to be able to offer this vaccine, to bring a mobile option to bear, and we can do that with collaboration with the state, but we also have our own team who is able to do that, and are really fortunate to have the doctors Weber, who are both retired, one infectious disease and one a family practice doc, who are working with us tirelessly to help really get this vaccine out because of their passion for the health of our community. So lots in motion, and happy to answer any questions.
Sure.
Dr. Johnson, not having to do with COVID, but influenza. Are the influenza vaccines available now, or will it be early September? I'm just thinking for myself, I want to space if I can get a booster, I want to space that out. So, and then
Yeah.
I know you'll be, you know, with the rise in RSV among children and even some adults, just thinking that as people are out and about more, we might see more of a lot of different respiratory illnesses.
I'm so glad you brought that up, because that's actually one of the things that I really want to get the message out first.
Yeah.
The preventive measures for COVID work for other respiratory viruses, right? They're all transmitted in droplets. So when you put your mask on, you're not only preventing the spread of COVID, but RSV, which has an unprecedented early spike in August. We typically see that virus in February, but we are approaching respiratory season. And usually the hospitals are gearing up for that, anticipating that they're going to have more individuals who need assistance with that. We know that RSV is not playing well with COVID. And so Dr. DeStefano from Children's will be bringing us some data about what they're seeing in some of our surrounding states with this, as they're a little ahead of us on the impact of kids, as well as then what is occurring here in Colorado.
And that'll be at our next Board of Health
Yeah,
meeting.
next.
Dr.
So,
DeStefano,
a
okay.
little teaser about
Yes,
why you want to
excellent.
come to the next board meeting. But to your question about influenza, absolutely. It is, we will be promoting flu vaccine. It is not being released early. We have not been seeing cases at this point. It is safe to get them together, but it's reasonable if you want to, you know, try to time them for your own comfort as well. But we are going to be definitely encouraging the flu vaccine, and you can vaccinate children with influenza vaccine as well as adults. So an important adjunct tool as we recognize the ongoing need for prevention.
Excellent. Yes, yes.
Dr. Johnson, Stephen, either one, you know, in this briefing or this presentation, we have cases, we have hospital admissions. In the past, have you covered deaths?
Yes. And Stephen, that is on our web page. So if you get on the data dashboard, elpasocountyhealth.org, and we are seeing deaths have typically lagged. And we are at a point of seeing just about one death a day again. And at one point, we were at Stephen, correct me, 1.87 deaths per day from the inception of this virus, just in general. Is that, and we're at 960 some, 970 some total?
You know, I looked just a few days ago and it was 0.56, I think over the last 7 days is the average, 0.56.
Yeah.
And I think if it was included in the past and we tracked it as it rose, then we want to include it in our briefings as it declines.
Absolutely. And we know that the reporting on our fatalities lags because the death certificate is signed at the hospital, then it arrives at the coroner's. I mean, there is a process to that. So there is some lag. But Stephen, where are we on that?
Yeah, absolutely. I mean, the deaths do lag in time, and the numbers, thankfully, in the end are so low, with the exception of the fall surge, where the death counts were multiple per day, very high. But since that time, they've gone down, and with the advent of vaccines protecting more of particularly the more vulnerable, the deaths have gone down. We can absolutely include that. Visually, it's harder to see the death bumps, which is why in presentation I did not include the slide.
Stephen, quickly, did you want to get back to the age demographics for the hospitals?
Fadi was able to crank out a couple slides that shows that over time, and I think he's trying to get it into the slide deck.
Okay. Doris, you had a question?
I was just going to say on Susan's report on page 29, I noted that the hospital admissions and deaths in the last 7 days, August 8th through the 15th, 51 and 7 respectively, hospital admissions 51 and 7, deaths from August 8th through the 15th. And that was, the admissions were more than double since the July 18th period. And the deaths were 6 more than in July for that period. It's there.
Yeah, but my point is that if we, in the past, have tracked in this presentation, cases, admissions, deaths, then we should continue to do that, especially if they're declining, just to give us a full picture. And I think you can understand why, right?
Sure.
It's an important, it's the most critical metric, right? The most important metric.
Well, historically, we see the deaths lag behind hospitalizations, but you're absolutely right. Keeping us abreast of all of that data.
Yeah.
One of the things around hospitalizations, to Stephen's point, which is really, and again, we should track this, that even if you're, vaccinated, you are less likely to be hospitalized, but your fatality rates go down too. So we would expect to see that impact overall, particularly as our more vulnerable are vaccinated or unfortunately have already succumbed. The other thing that I think is important to note is we look at hospitalizations. Our hospitals are still open for business. If you need your gallbladder taken out or you break your leg, they are available and will have services for that. And so when we talk about these hospitalizations and that admission pressure on the hospital, it impacts us on our other health metrics because of availability and the resources of staff and time, which is hard to calculate in this. So there's all of these other things that we are keeping in the back of our mind, which is why we pull these particular metrics out to really look at.
Sure,
Right.
I think there's great concern over cancer treatments that were postponed because patients were afraid to come in, and their treatment was delayed. So yeah. I 100% agree.
Well, and pressure on some of the pharmaceuticals. So some of our rheumatologic medications are being trialed in treatments for COVID, and so less access
Yeah.
for some of these other standard treatments. So it's really a lot of very moving parts. You're absolutely right.
And even though like deaths may lag, I think it's actually good news that hey, our death rates are declining steadily over. I looked at it just a few days ago, but over quite a while now, it's dropping down to 0.5.
Absolutely. In the springtime, I think we peaked at about average of 2 deaths a day. Now, we're down around 1. And just for comparison, although it's not apples to apples, but back during the fall surge, we actually went above 10, and these are in pre-vaccination days, but much higher detected case rates.
Great, thank you.
So we have about 19 minutes, and I want to be respectful to those that are going to want to make some public comments. We have probably less than a handful, some online, and I think maybe one, but I did want to just add it. I want to wait till Ted gets back to go over the slide. So Stephen, if you could hold off, and then I asked Deanne to come up here quickly. And as part of Dr. Johnson's slide related to the Vaccine Consortium and how we work with our partners, we are well poised to provide the boosters and the vaccinations when we are going to vaccinate the general population. And the way that we get our job done is always through partnerships and collaboration. And I know that there has been a lot of information out in the public, whether it's on a national level or on a state level. We are still continuing with our approach of collaboration, partnerships, and working closely with different multi-sectors. And we want to provide a little bit of insight into our ongoing partnership with our school leadership and our superintendents as part of this presentation. So Deanne, if you could give us a very brief update.
Thank you, Susan. So we have remained in close coordination with our Pikes Peak area of superintendents, as well as our school team responding to COVID, which includes designated COVID coordinators from public, private, and charter schools as well. And then also providing technical assistance to our school nurses via office hours and direct outreach as school nurses are navigating situations that arise within their buildings. These activities initiated during the previous academic year when our school partners were responding to COVID. Communication has continued over the summer, and we are now again coordinating those routine meetings so that we're all navigating this together. And I think one of the things that I would like to just briefly point out about our school partnership is that our school partners have demonstrated leadership throughout the pandemic in terms of responding nimbly and flexibly to evolving situations. And we enter into this school year building on that background that was created during last year's response. And to their immense credit, they deserve acknowledgement for all the adaptation they made throughout that response in the singular academic year, implementing a remote model of learning, hybrid model of learning, and in person, all within one academic year. We have adopted, the El Paso County has adopted the CDPHE school guidance, and we are following that locally. We have also provided our school partners with supplemental information about how they can work with us, the technical assistance that our team can provide. And we do have a team of 8 dedicated epidemiologists and disease intervention specialists who are dedicated solely to school response and supporting that element of our overall communicable disease response activities. And we are also still recruiting to expand that team as well to meet the demands of the school year ahead of us.
And, as far as the makeup with El Paso County, we have started to put out a children's and youth data brief to provide the leadership of the school some insight, and not only, for the public schools, there are charter schools. We have about 17 different school districts in El Paso County, as well as many charter schools, and we do meet with them from time to time, the charter schools. And one of the things that I'd like to emphasize is that we want to maintain open lines of communication. And we have been able to do that. And these have been extremely challenging times and managing numerous different disruptions. I too want to say that I have a lot of respect for the schools and their leadership in the charter schools because there is also complex needs of mental health, academic priorities, and they are working with us. And so I do want you guys to know that we have a good working relationship and open, and we are providing, as we have throughout the pandemic, transparent information data on our websites for folks to be informed with hyperlocal data and what's happening here as we can provide it. And Ted is not back yet, so if we can go ahead and just briefly do the hospital admissions and the age demographics, we'll catch him up, and then I will give it back to you, Dr. Tribush.
Sure. Thanks, Susan. So thanks to Fadi for grabbing these slides really quickly. So this slide is displaying a hospital admissions for El Paso County residents for COVID over time, again, month to month. You can see at the beginning, very elevated age as we detected the disease very poorly, and it was among the more at-risk older. You can actually nicely see the advent of vaccines, the effect of vaccines is that basically the average age, and remember average age is one crude statistic, but average age has been consistently declining over time. So that now what we're seeing is those hospitalized tend to be younger. It's quite clear a pattern. And the next slide is a mimic of the slide that we showed you for cases. Again, we're showing only the months of May, June, July, August, and this we're showing raw numbers of hospital admissions. Once again, you can see that if we look at May, you can see the numbers were higher, and the other months in the middle months, June, July, lower. In August, again, 3/4 of August in, pushing back up. And you can also, it's a little harder to read into this, but you can see that the people that do tend to be hospitalized do tend to skew older, but you can see the effect now of younger people being hospitalized, where if we looked at an earlier time period, it would be much skewed toward the older, again, principally because of the advent of vaccines and the penetration of vaccines within the older population in El Paso County. And again, these numbers on the left tell you the actual number of admissions. So for instance, 2029 age group month of May, there were 30 people admitted. And to be honest, yeah, so that's a raw slide, but that gives you a sense of the hospital demographics. Again, on this slide, 9 out of 10 of these people are not vaccinated among those eligible. So that even means, we can't get into eligibility till that second shot group. Questions?
Thank you, Stephen. And I also want to thank Fadi, one of our
Absolutely.
epidemiologists. He moved very quickly to put those slides together and put them up there for us. And I have taken some notes related to some additional briefings and what we will have as far as some slides. I wanted to emphasize when I started out this briefing for my director's report, the call to action. The call to action for our community is the prevention measures that we have been educating on, and not singling out one prevention measure over some of the others. It's the layered approach which increases health protection against COVID vaccine. There's not 100% prevention. However, this is what is going to make a difference. And we wholeheartedly, fully believe in the prevention measures that we have been promoting persistently throughout the pandemic. And you heard also, it's not on the slide, but the importance of good airflow also. And you'll be happy to know within this building, we've got great airflow. And I know that there was a system we have good airflow. So I think that's really important, and that the vaccine that we have as a prevention tool is superior as part of the prevention measures for our community. And we have a lot of access points for people making the choice to get vaccinated. And with the FDA approval, I understand that there was a study that 3 out of 10 people were waiting for the FDA approval to get vaccinated. So I expect that there will be a bump within some of our vaccination rates, and that's going to make a difference. What happens in our community matters to the schools and our shared goal of keeping kids in school. So that is critical. So we want to protect individual health, but we also want to do our part with protecting community health. And so our message has not changed. We have been consistent for these last 19 months as it relates to some of the prevention measures. It is a new novel disease. We do learn, and we provide that information as quickly as possible as we have that available, and wanted to give you guys a good grounding with where we are today. And as always, I want to say how stellar our local public health team is. They are working tirelessly, and especially our communicable disease team. There is a lot more going on than just COVID. We have gotten a lot of different zoonotic diseases, and not only some that are going back to the there's RSV, hand and foot mouth disease. There's foodborne illnesses. There's plague. There's a lot of different aspects that they're working on. So I do want you to know that they are working tirelessly, although you don't see them. They are quality, stellar. We've got a quality, stellar team for local public health, and I can't say enough to all of their expertise and their tireless work. So that is my director's report. I'll take any questions, but I know that we do have maybe about a handful or so of people that wanted to comment.
A few more.
Oh, okay. Okay.
Questions for Susan? Please. Great report. I want to especially also thank Deanne for her report about the coordination with the schools. I thought that was particularly helpful. And all of our presenters, Stephen and Fadi, and of course, Dr. Johnson. So thank you all. Okay, well, we get to the part of our meeting. We do this every month where we welcome public comment. And so we do have a number of people on teams who would like to make comments. So let me kind of shape the discussion just a little bit, if you don't mind. The real question on the table today is not about vaccination, not about whether or not our current vaccines are safe and effective. I think we've proven over and over again that they are, and that's our very best weapon in fighting COVID. The question is not even really about whether masks work. They do as part of a layered approach, and we've continued to recommend masks, and we're in line with CDC and CDPHE guidance, and they are part of a larger layered prevention measure. The question on the table today, I believe, is whether or not El Paso County Public Health should enforce a mandate for the wearing of masks in El Paso County schools. And that the mandate, if it was applied, my understanding is it would apply to staff and teachers and students and visitors alike. So I think that's what is in the public mind right now. And there was an article here in the Gazette this morning that said that the parents of school-age children are pretty much evenly split, 50-50. Now, I will mention this, and this is not under the category of sour grapes, but kind of. 5 of our 9 board members received threatening calls from persons who were insisting upon a mask mandate. It could have been an anti-mask caller, but it wasn't. In addition to the threatening language, which was somewhat graphic, our qualifications were put in question. Those are on the website. Those are available for anyone to view. I'd have to say, I think we've got one heck of a qualified board of health, just looking around and noting everybody's experience. The other comment was, do your job. It's what you're being paid for. This is a volunteer. Granted, we have some elected officials here, but you're not getting paid extra for being on the Board of Health. This is a volunteer position, a non-paid position, and it's because we want to be here. The last one is that private information of Board of Health members was compromised. This is just wrong. If you want to make comments to the Board of Health, we have that section on the website, a public health comment, Board of Health comment section. Feel free. A number of people do. So just to kind of tie up that comment, the threatening language and against Board of Health members, and especially any public health staff, is just not going to be tolerated. And I guess I've said enough on that. So anyway, we have 9, 10 perhaps people who wish to comment. They're all virtual today. And that what I'd ask is that we limit the comments to 2 minutes each. Well, there'll be a counter here on the screen. That the speaker needs to identify themselves. And particularly if you're part of a group that wishes to reinforce the message. Also, it's important to me whether or not you're an El Paso County resident, so I'd ask that you identify that as well. So our first commenter, if we could, is Adriana Card. Welcome.
Hello, thank you so much for the opportunity to be able to speak with you all today. I am a resident of El Paso County. I am a mom of a kindergartner in District 20, and I just wanted to bring up some examples of school children and masking. The New England Journal of Medicine published an article not long ago detailing how Sweden, who is not masking their school children, the number of deaths from any cause among over almost 2 million children in Sweden as of December 31st, 2019, was 65 during the pre-COVID period of November through February 2020, and 69 during 4 months of exposure to COVID, which was March through June 2020. From that exposure to COVID period, March through June, a total of 15 children with COVID-19 were admitted to an ICU. 4 of those children had an underlying chronic coexisting condition such as cancer, and no child with COVID-19 died. The Irish Post has decided officials have called mask mandates for children child abuse because of the psychological and emotional effects. Primary school students will not be required to wear face masks because the National Public Health Emergency Team and the Health Information and Quality Authority reviewed whether they should wear masks and determined that transmission between children and onwards to households has been low throughout the pandemic, and the mask wearing may exacerbate anxiety or breathing difficulties. The last one I'd like to bring up is a May study done by the CDC itself, a large-scale study of COVID transmission in American schools. Measures that were not found to have a statistically significant benefit were distancing, hybrid models, classroom barriers, HEPA filters, and most notably requiring student masking showed that it was not effective at all, although it was underreported. Thank you so much for your time. I appreciate it.
Thank you, Adriana, for your comments. Next is Kristen Grenier. Kristen, are you there?
Yes, I am. Thank you. Good morning. My name is Kristen Greiner, and I'm a resident of El Paso County with a first grader in District 20. I'm here today to speak on behalf of every parent who's concerned about the possibility of mask mandates coming back in our schools. I'm a current graduate student working towards my master's in public health. I've spent the last 2 years learning about the work of epidemiology and disease prevention. While I understand that COVID-19 is a public health concern, particularly for those 65 and over, I think we can all agree that enough time has passed to truly understand what piece of the population is at risk and which is not. Public health practice is based on the principles of equity, fairness, and empowerment. I believe in public health, we must give fair and balanced information to the public. We must make decisions for the good of all and not force mandates upon people that do not make sense scientifically. It is our duty to offer evidence-based facts and to empower the public to make their own educated decisions. Empowering people to lead healthy lives free of comorbidities is what public health should be focused on. Have we been teaching people how to eat healthier, get more vitamin D, and incorporate exercise into their daily lives? Over this pandemic, we've seen some of the highest COVID rates among states that have the most stringent mask mandates. We know that children need germs in order to build a robust immune system. Continuing to cover their faces and impede the natural exposure to germs is only going to cause superbugs and more dangerous outcomes in health, as we've recently seen with the influx in RSV cases. Per the CDC COVID data tracker, Chart 5, children in the 0 to 17 age group have a 99.997 chance of surviving influenza and an even higher rate of surviving COVID. I asked El Paso County Health remembers its role to recommend a course of action and that it does not have the authority to mandate a medical intervention, AKA masks, to an entire population. There shouldn't even be a debate, and the rights for parents to make choices for their children should be upheld. Thank you.
Okay. Well, thank you. Thank you, Kristen. We're now going to welcome the comments from MG Peterson. Go ahead.
Good morning. Thank you for letting me speak with you this morning, and I absolutely reinforce what Adriana and Kristen have shared. It is well documented that COVID-19 is not going away. We've heard from immunologists, virologists, and epidemiologists from around the world that this is very true. No one can make this virus go away, and therefore it's how we best navigate through it. Up to this point, messages contrary to the truth of making the virus go away of not being able to make this virus go away are completely counterfactual. Beating the virus, annihilating the virus, that cannot happen. And therefore, I invite the Board of Health of El Paso County to engage in other measures, like Kristen mentioned, to inspire people to have optimal health in their lives and to not be so fearful of COVID-19. We know that masks serve no level of protection. They do, however, lower oxygen levels in the blood while raising carbon dioxide levels. They affect respiratory physiology function. They actually trap exhaled viral pathogens, which increases the severity of viral load. They collect and colonize viruses and bacteria and are dangerous for those with asthma and respiratory issues. They inhibit children's healthy social and verbal development. And youth, we know, are not the super spreaders of the virus. And when they get sick, the majority do not get an acute case because the majority do not have comorbidities. And I want us to remember that there was a significant increase in suicide among high school students during the severest COVID restrictions. So the preventative measures that were put forward this morning are counterfactual, and by promoting them, we once again completely disregard their negative impacts. And I also, with Kristen, want the board to remember that it is making recommendations, not mandates. Ultimately, it is in the hands, constitutionally, it is in the hands of the parents to decide what is best for their children. Thank you very much.
Okay. Thank you, MG. Our next public commenter is Marion Hordequin. Welcome, Marion.
Thank you. I appreciate the chance to talk with you today. My name is Marion Hordequin. I'm an El Paso County resident. I live in Colorado Springs and have 2 children in public schools in the city. I'm also a teacher and care deeply about education and about the physical and mental health and continuity of learning for all children in El Paso County. I'm speaking today to ask you to require additional COVID-19 mitigation steps to protect students, faculty, and staff and school districts throughout the county in alignment with recommendations from CDC, State of Colorado, and American Academy of Pediatrics. More specifically, I'm asking you to please issue an indoor mask mandate for teachers, students, and school staff while the incidence of COVID-19 in our community is high and while children under 12 are ineligible for vaccination. As far as I'm aware, only 2 districts in the county, D12 and D14, currently require students to wear masks indoors. Mitigation measures in other districts are minimal, and in fact, Governor Jared Polis and CDPHE Director Jill Hunsaker-Ryan wrote to all superintendents across the state last week expressing concern about the lack of mitigation in many districts throughout the state, recommending masking and additional measures be implemented. Many school districts have gone to a mask optional policy, and I don't believe that that's working. Very few students in my kids' schools are wearing masks. And I'd like you to consider that District 20 has now recorded 74 cases of COVID-19 since the recent start of the academic year, and that there are now 483 students in D20 and staff in quarantine. This level of in-school exposure is risky to kids, families, and our community, and it disrupts in-person learning with significant educational, social, and emotional impacts on kids. You are medical experts, and you're also knowledgeable about COVID-19, its impacts, and its spread. You're also aware of the surge in the Delta variant. I respectfully ask you to act on what we know is effective in mitigating the spread of keeping our kids safe and healthy and in-person learning. Thank you.
Thank you, Marion. Our next commenter is Kara May Coffey. Welcome.
Good morning. Thank you for serving our county on the Board of Health. This is the first board meeting I've observed, and I thank you for accepting my comments. My name is Kara May Coffey. I'm a parent of 4 children in El Paso County. I want to comment in relation to school policies with regard to masks in schools. Last Monday, a friend and I began an online petition to gather signatures from parents who support the current policy of parent choice when it comes to masking our children. As of this morning, we've received over 530 signatures. I'm speaking today to represent these voices, parents supporting mask choice for El Paso County schools. We want to voice our strong support for a policy of parent choice. We request that masks continue to be encouraged yet optional for our students. We believe it is the role of a parent to assess their child's risk and choose what is best for their child. In Colorado, the overall recovery rate for COVID-19 in cases for children aged 0 to 19 is 99.99%. This is according to numbers found on the Colorado Department of Health website. Since March 1st, 2020, 4% of our hospitalizations in El Paso County have been children under the age of 19. Despite concerns of increased cases due to the Delta variant, in the last 90 days, hospitals for children 0 to 19 in our county remain at 4% of overall COVID-19 hospitalizations, with 0 deaths in children. The statistical data does not support a policy which mandates masks for all children in a one-size-fits-all approach. We trust parents to be the best judge of what is most effective for keeping their children safe and healthy overall. We want to voice our support for you and your current policy. Please continue to allow masks to be optional for our children. Thank you.
Thank you very much. Our next commenter is Jason Jorgensen. Welcome, Jason.
Yes.
Thank you. Good morning. My name is Jason Jorgensen. I am a native to Colorado Springs. I do serve on the D11 school board, but I am only speaking on behalf of myself during this time. First off, I want to say sorry that you are receiving threats to you and your board. That's inappropriate and was hard to hear. I apologize that you're taking that on. I hope that people will straighten that out. The next thing is we mentioned a lot about vaccines here, and the vaccine's effectiveness actually in a recent study has dropped from 91% to 66% effective with the Delta variant. So while it's still helping, it has dropped in its effectiveness, and it's still actually, you said the vaccinated people are able to still be infecting others. And so just some conflicting information that you had this morning. But in other notes, thank you for the children and youth data brief. I appreciate that. I look forward to getting that as a member in our community. It looks like even though the vaccine is approved, that the trials are still going to be ongoing until 2023. So you're still in the trial area even though you're approved, and so people need to be aware of that. The next thing is I would love for us to spend some of our COVID money, our federal and our state funds, into looking at natural immunity. We have millions of dollars. D11 has millions of dollars in these ESSER funds, and we have yet to allocate any sort of resources into testing for antibodies. Is there any way that we can, as a Board of Health, take people with past positive tests and say, hey, come back in 90 days later, 6 months later, a year later, and let's get you an antibody test, and let's see how natural immunity looks for those individuals in our area. There's national tests that are available, but I would love for us to have our own data to use as a source so that we can use that when determining herd immunity levels in our state. Lastly, there's a CDC study that was put out in May of this year that says student masking is not statistically significant compared to staff and teacher masking. And just want to leave that last fact with you. Thank you for your time.
Thank you, Jason. Okay. Next on the list is, who signed up is Gretel Reich. Welcome, Gretel.
Dr. Turlish, I don't see her on the meeting.
She's not, okay.
Nor the last two on your list.
Okay, so the other two maybe dropped off?
Yeah, they never joined, as far as I can tell.
Okay. All right. Well, these are always valuable comments, and that's why we do it. It's an important part of our monthly meeting. I just want to very quickly comment on what a fantastic job I believe our public health director is doing, and in two specific ways. Is first of all, in initiating and then carrying on with your staff this interface with the school districts. I think that this Children in Schools report is very important and very helpful, and I think we'll be referring to this frequently. And the other thing I'd like to comment on is your relationship with the CDPHE and the close and frequent contact that you have with our state health department. This provides benefit to our local health department in so many ways. And the fact that you can just call them up and get the latest and greatest update on what's going on and ask good questions, and they respect you and listen to you. I know that. So anyway, thank you for those two things that you've been able to carry on with during this COVID pandemic. Board of Health member comments. We can linger a little longer here, and yes, Commissioner Bremer.
Thank you. I just wanted to thank all of those who came for public comment today. And clearly, this is it's an emotional topic for people to discuss, and the professionalism, decorum with which each of you presented very well laid out arguments today is just so greatly appreciated. So thank you very much for taking the time to share with us your heart on a very emotional issue, really, for everybody. But I want to commend you particularly, every single one of you, for doing it in a very, very planned, orderly, and for the most part, data-driven way. That is how this board makes decisions. And of course, we love to hear anecdotally how these data-driven decisions affect you. But I just appreciate the way in which the public comment was approached today.
Hear, hear. Other Board of Health members? Yes.
Dr. Turbish, this is Councilman Donaldson. I just want to essentially second what Commissioner Bremer said about the polite, professional comments that and input, really, and it helps us to get that from the public. So I encourage citizens to do that and to do it just like, I think there were seven. Seventh one wasn't there. There were six. The six of you just did. And that's beneficial for us, and we really do listen. So thank you.
Anybody else? No? Okay. Well, good meeting. Let's see, when is our next meeting? When in September? There you go. How about that? Doggone, Vicki, it's hard to get one past you. Okay, so Wednesday, September 22nd at 8:30, we'll see everybody again. And then, of course, in the meantime, I'm available for calls or emails or any other means of communication from any of the board members, and likewise, Susan. Okay, move to adjourn?
So moved.
Second?
Second.
Okay, meeting ended.